Hello, I'm Dr. Dylan Kruger. I just wanted to film a quick video here to go over some common topics that I've been getting a lot from my patients involved with corticosteroid injections. Most commonly cortisone is kind of the big one people refer to, but broadly speaking, all corticosteroid injections for knee osteoarthritis. So let's take a look here. I want to cover 3 studies today, and if you do have any questions, always shoot me an email and I'll be happy to respond. I'll also respond in our knee pain support group as well if you do have questions about this topic as well. So basically, corticosteroids have been around for quite a long time. It's a very common treatment for knee pain, particularly knee osteoarthritis. So physicians will typically recommend a corticosteroid injection if you're unresponsive to more conservative measures like non-steroidal anti-inflammatories. Those would be ibuprofen's kind of the big one, aspirin, naproxen, etc. Or other over-the-counters like Tylenol extra strength, Tylenol arthritis. Some physicians might have you try physical therapy before they jump and go to a corticosteroid injection. Some physicians might go there right away, so it just kind of depends on them, their preference, but it is extremely common treatment. So what are corticosteroids? They are an anti-inflammatory agent that is a steroid that is injected into the knee joint for knee pain associated with knee osteoarthritis. So it's a very, very strong anti-inflammatory shot to take inflammation out of the joint to give a patient symptom relief for the pain with the arthritis. And it's been around for a long time. I'm sure many people know friends or family member that have had these steroid shots. They're super common. So let's take a look at a few interesting studies that have came up and made us question cortisone use in orthopedics and pain management. So first I wanted to look at this new one. It's been out since April 2020 in the Bone and Joint Journal, which is an orthopedic journal. So basically on this study, this was a long-term follow-up study. They looked at over 3,800 patients, so 3,800 patients, and they were, the objective was to assess if these corticosteroid injections into the knee joint are increasing your chance of ending up in total knee replacement surgery. So they had 3,800 patients. Not all of them had steroid injections, so it was broken up into different groups. So when we're looking at this study, about 800 of the 3,800 patients ended up having steroid injections, and this was monitored over a 9-year period with follow-ups along the way, including baseline imaging and then the final imaging of x-rays and MRIs. So what they found was out of the 800 patients in this group that had steroid injections, 31% of those ended up having total knee replacement. So as we can see, and this kind of matches up what I've seen clinically, is once you start going down the steroid injection route, the ultimate endpoint is surgery. Whether you like it or not, that's kind of where you're going. So it's important for the physician to educate the patient. They should be fully aware of the path they're choosing. Now, another finding they saw in here is in the group that didn't do corticosteroid injections, only 5% of them ended up having total knee replacement. So the group that had steroid injections, 31% ended up having total knee replacement, versus the group that didn't, only 5% ended up needing that surgery. They also found that per steroid injection that you have into your knee, you increase your chance of having total knee replacement by 9.4% per injection. So think about that. If you do a series of 3 steroid shots per year right now, think about how much you're speeding up that chance of having surgery. You're fast tracking it. That's where you're going with this therapy. So this was very interesting, and it was a long term. So they followed this through multiple clinical sites over 9 years to gather this data. So very in depth. Now, second study I wanted to look at came out in 2017. Now with this one, it was only 140 patients, and it was broken up into two groups, so about roughly half and half. So on this study, they were looking again at the effects of steroids on your joint as far as reduction in long-term pain. So they had out of the 140, it was divided up in two equal groups. Half of them would just get a saline water shot, so that would be the placebo. Half would get a corticosteroid injection, a steroid injection into the knee. And they did this at every 3 months for a period of 2 years. So they measured baseline pain and function and imaging, and then every 3 months they would follow up and track this over 2 years, and then at 2-year point they got their final data and then the final imaging. So what they found is at every 3-month follow-up, there was no statistical difference in pain reduction between placebo and steroid injection. No difference in pain every 3 months. And then at the 2-year follow-up on imaging, both groups had a reduction in cartilage in the knee. The corticosteroid group had significantly more cartilage reduction. So when we're looking at steroid injections, the pain relief wasn't even picked up in here. So if there was pain relief, it was in a less than a 3-month window because it wasn't even observed statistically in this study. And the long-term result was the joint was worse off after 2 years. So this also matches the previous study I mentioned where you have an increased chance of total knee replacement. And this would support it by the fact that your joint is now worse off after 2 years by repeated steroid injections. Now the last study, and I've already done a video on this that you guys can check out that we have up on our YouTube page, but this was the biggest trial, and this was a meta-analysis. So this looked at a total of approximately 3,500 patients, and it was a meta-analysis that examined 30 randomized controlled trials. So these are the best type of trials and have the most scientifically validated data that we can utilize in clinical practice. So when we're looking at this meta-analysis that looked at corticosteroid injections versus hyaluronic acid injections, which is another common treatment for knee osteoarthritis. And then it also looked at PRP injections, platelet-rich plasma injections for knee osteoarthritis. So once again, 3,500 patients, a meta-analysis that examined 30 clinical trials. Now what they found is on the 12-month follow-up that PRP was more effective in pain reduction as well as increased functionality of the joint than corticosteroids. And in fact, let me pull this up here. At the 12-month follow-up, corticosteroids were less effective than placebo. Let me say that again. Corticosteroids less effective than placebo at 12 months. And this is measured on the WOMAC pain assessment scale, which is very detailed. It not only measures the patient's pain, but also functionality based on common daily living activities. So we had 3 studies here that I looked at. We saw that over a long-term period, 9-year period in the first one, you have increased risk of total knee replacement, and that risk goes up by 9.4% per injection treatment with corticosteroid. The second study shown it is no statistical difference in placebo at every 3-month interval, and you have less cartilage by getting the treatment. And the third meta-analysis that looked at them all said it is no better than placebo, and platelet-rich plasma is statistically much, much better for pain relief and increased function. So we need to start implementing the most up-to-date scientific data when we're treating our patients. and patients need to be aware of this. Now, this is not to say corticosteroid injections do not have a place in medicine or in a place with pain management, orthopedics, and knee pain. Now, a patient, it kind of depends on what they want from you. What are they trying to get out of the therapy? So if their number one objective is just to have insurance coverage, we might look at a corticosteroid injection because it is widely covered by insurance. So if all they care about is not spending any money out of pocket, they want it just completely covered, okay, let's look at steroid injection. We also might look at it if you're a high-level athlete, you're a professional athlete, maybe you're a high-level amateur athlete. Say you have a marathon and you've been training for it and it's your lifelong bucket list goal to complete this marathon. And you, along the training process, you end up having some knee pain and you don't care. You just want to finish this marathon and you'll figure it out later. Okay, we might look at a corticosteroid injection in that case. Say you're a professional athlete, you got the playoffs coming up, your team needs you, you're a part of the lineup, you play a lot. We might look at a corticosteroid injection in that case as well. So we're only looking at it, one, if you only care about insurance coverage, nothing else, and two, if you have a high-level athletic event coming up that you're trying to complete. Now, if your long-term goals are pain relief, increased functionality of the joint, and avoiding surgery, then the last thing you want to do is have a corticosteroid injection, because we have a plethora of evidence and data that suggests it makes the knee worse. So it's not statistically significant at reducing pain, it wears the cartilage down, and another study pointed out that you have about a 6% chance of other side effects of the corticosteroid injection. And they mentioned the other side effects could be osteonecrosis, where the bone is actually dying off and deteriorating. Another side effect is what's called a subchondral fracture. And these are tiny little cracks in the bone, tiny fractures right under the cartilage in your knee joint. So they're subchondral fractures. You get those as a potential side effect. And another long-term side effect of continued corticosteroid injections is rapid joint degeneration. So we need to be aware of all these factors when we're looking at the best injection-based treatment for knee osteoarthritis, and we need to explain these therapies and educate the patient about the best choices for them and their lifestyle moving forward.